I'm Riley Lipschitz. I'm a general internist and primary care provider at UIMS. I'm an associate professor in the Department of General Internal Medicine. Um, I'm also the chief medical officer for population health at Baptist. So I'm sort of splitting my time between these two institutions to work on big population health projects. So today's discussion is called Place Matters: Geography and the Social Determinants of Health. And it's a great topic. I'll tell you that there's a lot of movement in this space and will continue to be. So hopefully it's interesting to you. I have nothing to disclose. The big objectives for today are to describe the Healthy People 2030 place-based framework for social determinants of health, to identify some data sources to evaluate place-based social determinants, and then to evaluate some successful interventions to improve social determinants, specifically social and community context and the neighborhood built environment. So for today, the first thing is looking at this CDC's place-based framework. When we think about health, traditionally physicians are taught that healthcare is the locus of health, when in fact, we know that it's much more broad and that the healthcare and quality of care is largely a sliver of someone's overall health experience and what that means. So when you think about trying to put the frameworks in place to make sure that we understand the broad picture of healthcare, the CDC put this bigger infrastructure for us to start thinking. One is education access and quality. That makes sense. High school graduation rates, college attendance rates, literacy, early childhood development, all of that obviously impacts health. Healthcare and quality, that's our space that we tend to live in. Neighborhood and built environment, which we're going to talk a lot about today, but it's really the bigger picture of where one lives. What do they experience in their day-to-day and their neighborhood violence and in their neighborhood environment and their when they walk out the door, what do they see? Social and community context is, I think, often what we traditionally think about in social determinants of health, and economic stability is that connection between financial resilience, resources, and healthcare outcomes. So the social determinants of health pie chart, I talk to med students and residents about a lot, because clinical care here in the yellow accounts for maybe 10%. Some would say it's up to 20, but 10% of a health outcome. So how well someone lives or how long someone lives is really not dependent on what we do in the medical sphere. And yet we tend to think of ourselves as kind of the arbiters of how well or how long someone lives. In reality, health behaviors, social and economic factors, biology and genes, the physical environment, it's that really accounts for the bulk of their health outcomes. And from my perspective as a physician, and particularly as a primary care physician, which you guys as often you would know is kind of chess by mail, right? We make a little change, they go back out into the real world, into their own environment, they come back to us a couple months later, we see how that change worked. But it's freeing to recognize that the clinical care is a sliver of this person's health outcomes. And so it gives me solace in two ways. One is to acknowledge that, things don't live and die by the work that I do. It's an important part, but it's not everything. People are autonomous, who make their own decisions, who live in environments, and that we see a sliver of their lives. But also, it really provides some context and frameworks to think about, if we're really that committed to improving outcomes for our patients, then we have to be more expansive in thinking about what those interventions are going to entail if that's our big goal. So when you think about social determinants of health, the conditions in which people are born, grow, live, work, and play, there are a variety of systems or levels at place. There's the individual level, which is what we think about, my day-to-day. The community level, which communities are we engaged in? What places do we frequent? And then the systems level, which is probably bigger institutions, systems, policies, governments, cultural norms, institutional racism, the challenges that are multifactorial when it comes to someone's health outcomes. So this is the adverse childhood experiences pyramid, which I find kind of mind-blowing, because as we know, Arkansas is one of the leaders in the nations of adverse childhood experiences from our youth, and that as adverse childhood experiences compound, they lead to an exponential increase in morbidity and mortality as we see that rise. And what you're going to see here is this generational embodiment historical trauma. Next up is social conditions, local context. So where someone is born into, that they have zero control over, is already sort of setting up the foundation of what their health outcomes might be. Remember, when we talk about social determinants of health, nothing is definitive. So though we talk about this pyramid, that social conditions, local context, historical trauma, it can set the stage for poor health outcomes, but it is not a requirement. And I think, again, there's some language issues that we have to be really thoughtful about. But going back to this pyramid, social conditions, local context can then lead to adverse childhood experiences, which lead to disrupted neurodevelopment, social and emotional cognitive impairment, the adoption of high-risk behaviors, disease, disability, social problems, and early death. I mean, it sounds hyperbolic, but in reality, we see this in our patients, how the continuum of their lives, the trajectory of their lives, is played out in so many ways of how they access the healthcare system and what happens to them. So this is just a quick segue to talk about language. When we talk about social determinants, precision matters. And I feel really strongly about this because I think social determinants of health, SDOH as a concept, is kind of ubiquitous and it's being thrown around in lots of health circles, but it will do us a better service if we can be a little more specific about what we're talking about. So social determinants of health impact everyone. You, me, our patients, our kids, our parents, our neighbors. It's not it's not something you don't have. We all have social determinants of health, and it's not positive or negative. We tend to think about social determinants of health as a bad thing, right? Like we only bring it up when someone has a problem. They are facing eviction. That's a social determinant of health, as opposed to housing being the SDOH. So from a trajectory perspective, and being specific, I like the way this article presented it, which is social determinants of health are the big umbrella that we all have. Social risk factors, kind of going back to that ACEs pyramid, is things that put someone at risk of having a poor health outcome, or mainly put them at risk of having an unmet social need. So social determinants of health, social risk factors, social needs are three distinct things that require an important thought, or at least approach, when we talk about how do we discuss social issues. And that's partly why I like the shift away from SDOH as a term to health-related social needs. You may start hearing this, or people will say HRSN. It took me a minute to understand what they were saying, but health-related social needs is something we can target from a healthcare system, right? Like I can address someone who was at risk for food insecurity and then actually was missing meals. Now they have a social need that we can address with a food pantry, for example. So along kind of when you're thinking about screening your patients or talking to trainees about this, the trajectory would be social determinants of health is health access to food. A social risk factor is you may be in an environment or in a community that is at risk of food insecurity. And then social need would be you're in an environment that's at risk for food insecurity and now you are missing meals. So you have this unmet social need that we need to address in order to improve your health outcomes. So just thinking about place in this place-based framework, where you live, the streets you walk on, the institutions and public transit, and all the things that you see in your day-to-day of your neighborhood is impacting your health. If you also think about it, the places in which we live are uniquely tied to public goods and public resources that are also doing so, that are the policies from our healthcare institution as well as our government are affecting this. So this is my place largely, right? Like I go to work at UIMS. That I live in a nice city. I go, I can walk through my neighborhood and I can go have a nice breakfast at Hill Station. I can ride my bike on the Big Dam Bridge. I have a cute dog who lives a nice life. This is my place in many ways. And so when I start thinking about these health related social needs or social determinants of health, the places in which I'm engaging or have access to have the opportunity to improve my health outcomes. But here's same city, different place. Arkansas ranks 43rd in children's well-being. That's certainly not the place that my kids are being raised, but it's the place for many Arkansans. Violent crime has increased since 2021. This was a photo of a dilapidated house for sale on Zillow that I found that was not that far from UIMS. We think about some of the homeless encampments. This is right under the bridge downtown. And then this Arkansas Kids Count, study after study would show that Arkansans are at increased risk of food insecurity, of social instability, of financial instability, of increased adverse childhood events. 40% of Arkansans are working poor, or what we would consider ALICEs, asset limited, income constrained, employed. So 40% of Arkansans are really one health crisis away from major financial trouble. The places in which they're circulating their lives are very different from the place in which I'm navigating mine. And that's important because it's something we need to consider. So when we think about health outcomes, remember, health outcomes are morbidity and mortality, how long and how well you live. This image, I'm sure, surprises no one. Poor health outcomes are unequally distributed across our state in areas and places that have their own social, economic, financial challenges. So when you look at countyhealthrankings.com, which is a great resource because anybody who's interested, particularly med students, I often will send them there, can start to get a better sense of what do the health disparities in Arkansas really look like? Geographic disparities in life expectancy are not fully explained by race and socioeconomic status. So there's a lot at play that often is kind of opaque in the research. So that's important to know. And sometimes we think about things that are causally related that we haven't been able to prove out. But just looking at these gaps in life expectancy between Benton County, Pulaski County, and Monroe. So Monroe County is like where Clarendon and Brinkley are. A huge increase in premature death. The gap in life expectancy is greater than the gap in life expectancy between the US and Honduras. So across multiple factors, when we're looking at quality of life, healthy behaviors, high risk health behaviors, they tend to be concentrated in certain geographic areas. But as I said, this disparity in health outcomes isn't just explained by race and socioeconomic status. There are other things at play. So a really interesting article came out of Health Affairs that talked about population well-being as a measure. And what population well-being was they incorporated 6 domains of one's physical, emotional, social health and surveyed them. So how you perceived your population from a well-being perspective increased your likelihood of good health outcomes. The lower end of that scale, so for every 1 standard deviation increase in well-being, your life expectancy went up. The converse was true for 1 standard deviation below, your life expectancy went down. So there are multiple confounding factors that all work together to talk about what happens. So as I was working through this talk, I went through and updated the evidence and looked at the studies, and There was a great whole series of articles. In fact, the entire issue of Health Affairs in February was dedicated to housing and health. So we were really looking at a variety of articles, a lot of them I'm going to talk about today. But when we look at the evidence when it comes to health outcomes and healthcare costs, there were four big pathways in housing and health. One is stability. So how stable is your household? Two is quality and safety, which is about, what are the conditions inside the home like, the safety of your house? Affordability, what percentage of your income are you having to spend on housing? And then sort of the characteristics of the neighborhood as well, which is, what does the environment look like? The green space, the sidewalks, the potholes, the broken window theory. These are the big four elements that the evidence is looking at for housing and health, and then the various sort of pathways in which studies have come out. So just focusing on neighborhoods for a minute, because I think that's more expansive in terms of place, right? The place matters, the neighborhoods that we live in. Thousands of studies are documenting sort of the clustering of health conditions by neighborhood and the association between neighborhood characteristics and poor health outcomes. Sadly, a lot of this research wasn't designed to support these claims, so it tends to be sort of causal in relationship. So as we continue to look at the current level of research, there's a lot of work to be done. But in general, these studies would say the disparities in neighborhood level resources and conditions, particularly when we think about social deprivation, neighborhood deprivation, food deserts, the social vulnerability index, which you can get through the University of Wisconsin. And now CMS is using the social vulnerability index as a way to kind of up the support for certain vulnerable populations. But these are the areas in which they start to think about it. So institutions, what institutions are available in the neighborhoods in which you live? Is there healthcare there? Do you live in a medically underserved neighborhood? Do you have access to transportation? How hard is it to go from one place to another? Do you have grocery stores that are well stocked and nice? Do you have libraries for your kids to go to or to check out books or have access to resources? Do you have community organizations, police stations, gas stations, corner stores? What are the institutions that are supporting your community? Second, physical characteristics, sidewalks, playgrounds. What's that local climate look like? There's a lot of work and research around green space and access to water. So and I don't mean drinking water, I mean blue space, open bodies of water that can have been shown to improve health outcomes. The social conditions of your neighborhood, violence, safety, collective efficacy and power is an interesting one because that sort of speaks to community engagement. So do the people in your community feel like they have a collective efficacy to improve their community or a collective power to improve their community? Or is it the opposite, right? There's a lack of power and a lack of efficacy, so a sense of disengagement. And then these social networks and social norms, that speaks to the type of people who are in your community, in your neighborhood, that you're tending to work with, right? Or play with or spend time with. Is there an increased risk of smoking? We know if you're around smokers, you're more likely to smoke. What's the rate of obesity? If you're around more obese people, you're likely to be obese. Mental health, that the sort of contagion of, to some extent, of unhealthy behaviors is real, and we know that. So if you're in a neighborhood or a community where this stuff is more commonplace, you're much more apt to have it yourself. So what do we do, right? Can we just make the neighborhoods better? And this is a quick note on a study on gentrification, which came out in that February article of Health Affairs. It looked at 6 large US metropolitan cities, New York, Chicago, LA, San Francisco, Denver. And then they tried to look at these key contextual determinants of health that were known to affect mental and physical outcomes. That was healthcare access. So that medically underserved areas was their access to healthcare, social deprivation, air pollution, and walkability, right? These neighborhoods that you can walk at. And what they did is they took neighborhoods that were consistently below the poverty line, and then over time saw a substantial increase. And I can pull these numbers for you at another date, or I can show you the access to the article. But that was their measure of gentrification. If over a set amount of time the neighborhood improved substantially, then it was a marker of it being gentrified. So what were the outcomes? So overall, there was an increase improvement across all groups for access to healthcare. So across all racial groups, there was more access to healthcare. There were fewer medically underserved areas. Unfortunately, there was an increase in social deprivation, a reduced life expectancy amongst Black, Hispanic, and people of other color, of sort of an undefined racial group compared to the white or Asian counterparts. So for white and Asian people in gentrifying neighborhoods, the white communities largely stayed the same. Asian communities saw an increase in life expectancy, but Black, Hispanic, and other communities saw the opposite. So gentrification, when we would say, well, I'm just going to invest in my neighborhood, I'm going to make it nicer, which often some of these policies are purporting, has the unintended effect of making things worse for a subset of already vulnerable groups. So now, what do we do about it, right? Like, we've set the stage that place matters, geography matters, your community, your neighborhood, your home. But as a healthcare institution, what do we do? So we start with screening, and everybody knows this wheel, the EPIC wheel, where we're trying to screen people. CMS came out and said it's going to be mandated to screen Medicare recipients for social determinants of health. But the problem is that if we screen people for unmet social needs without giving them any meaningful way to improve those or to meet those social needs, it's an undue burden on already vulnerable people. So from a health systems perspective, I find that we need to be very thoughtful about linking, or being prepared to link, the things that we're screening for with an intervention that we're prepared to offer them, or at least a resource that we're prepared to offer them. So when it goes to assessment, which is just this top area here, we assess, which we're already sort of gearing up to do, but now we have to really connect the whole circle to offer ways to educate, inform, empower, to mobilize communities, to work on policies, to link to community resources, to evaluate that all of that is working. And realistically, in this very complex and expansive wheel here, healthcare has a big role to play. And it's going to be an ongoing issue to figure out how we fit. So here, the last bit of this talk is largely going to be about talking about some of the evidence-based interventions so far. So one is to think about, well, what's the return on investment for investing in these housing or healthy communities? And often, if you look at traditional ROIs, it didn't pan out for healthcare institutions. So in this article by Health Affairs, they looked at creating a social return on investment, which was the triple bottom line, right? It was something which I kind of liked, because we talk about the triple aim all the time, which is we need to capture the intervention and the investment, the return of our investment in the economy, the environment, and the people. So not just on the financial frame, but the idea that by investing in our community, there's a social return that is more expansive than a dollar for dollar. So Bon Secours health system in West Baltimore invested in 800 units of affordable housing across 12 properties in West Baltimore. And what they found was that for every dollar in operating cost of these housing complexes, it generated between $1.30 and $1.92 of social return. So this idea of our return on investment is more robust when we look at it through the lens of the economy, the environment, and the people. And what they're seeing is that by pushing forward with investments in community housing, it's improving across multiple lines of business for them. Here's a study that came out on children's healthy development. It was a randomized controlled trial to determine the impact of housing vouchers. So they started in 2 cities, Cleveland, Ohio, and Dallas, Texas. It was a lottery system that had basically winners and losers. A winner got access to an extra housing voucher. And then the researchers continued to study to see what was the impact of moving into a better community based off of this housing voucher. And what they found, so the first information or early studies are around family stress and caregiver stress. So what they showed was that mothers reported, and this was largely focused on mothers and children, mothers reported the lowest level of parent stress when they were only paying 30% of their income for rent, which is the historical standard for defining affordable living. And that's what was able to be achieved with a housing voucher. And then in turn, by having the housing voucher, it allowed them to feel safer in their neighborhood, which caused lower parent stress and started to push the boundaries for statistical significance. So by investing with housing vouchers in our community, it can lower family stress. Ideally, that lowering family stress will improve outcomes. And thinking back to the very beginning of the talk, those adverse childhood experiences, investing now, we're sort of investing in the long run for these kids when it really comes to improving their overall health outcomes and their morbidity and mortality. This is a particularly sad study to think about because in 2005, there was a forced disenrollment of Medicaid for TennCare, which was Tennessee's Medicaid. And so they retrospectively looked to see what was the association from disenrollment in Medicare and Medicaid with evictions. And it should come as no surprise, there was a 27.6 increase in the average number of eviction filings over 4 years from 2005 to 2009, and nearly a 25% increase in completed evictions. So if anybody read that book, Evicted, you will be well aware that once someone goes down the path of eviction, it creates a cycle of problems, not only for their ability to get stable housing, but well beyond in terms of financial stress, social stress, personal instability. So if you're keeping in touch with the news or have a sense of what's happening in Arkansas, Arkansas's unwinding Medicaid post-COVID has been a huge amount of disenrollments in our Medicaid population. I know I've seen it a lot with my patients. Patients who were on Medicaid are now being disenrolled for a variety of reasons. And we've successfully disenrolled, which I think is a nicer way of saying kicked off, roughly 73,000 Arkansans. So in the next 5 years, what's going to happen? I don't think it's a very big stretch to see or to imagine that what happened in Tennessee will probably also happen here in Arkansas. We know that when patients have access to insurance, it changes the landscape of their personal health outcomes because there's an increase in financial stability, there's a decrease in emotional stress, and then just generally the ongoing fear of what's going to happen if I get sick. With a stronger insurance infrastructure and with expanded Medicaid, it's played a huge role in I think health outcomes across the board. So lastly, when it comes to hospitals investing in housing, we're going to continue to see movement across the board in these sorts of projects. This article from the New York Times came out yesterday. So as I was wrapping up this slide, I kind of was looking for images of hospital investment, and literally 3 hours prior, this article came out, which talks about in hospitals, affordable housing got the long-term investor it needed. So there was a series of examples in this study or in this article that talked about healthcare systems and insurance companies investing in affordable housing. Aetna invested nearly $27 million in 192 affordable apartments in New Orleans. Now, this was a $60 million investment across multiple lines, so it was a big community partnership. But of those 192 affordable apartment complex called the H3C, which was Commerce, Culture, and Community, there was an embedded medical clinic, there was a gym, there was a grocery store. Tenants had access to a variety of resources within this one community in New Orleans. But then in turn, researchers from Louisiana Public Health are going to study patients' health outcomes and then use this data to determine what are the effective ways that health systems can work with developers to improve health outcomes. So, if you think about it, 192, roughly 200 affordable housing units in one downtown city is going to care for a huge number of potentially vulnerable people. And then in turn, that has a ripple effect across a really long game project. And then jumping on the bandwagon, we're seeing this in multiple places across the country. Kaiser Permanente invested $400 million to fund affordable housing through its Thriving Communities Fund, which is trying to build or preserve 30,000 units by 2030. So when we see the money following the path of addressing these social needs, I think now we're going to see where the rubber meets the road for really trying to connect health systems and broader community-based organizations, especially housing. Medicaid has waiver dollars through both federal and public state programs that you could utilize, which we don't utilize in Arkansas, but they're utilizing across the country. Washington State provides $140 million to build homes for vulnerable citizens. So really being thoughtful about understanding the shifting policies for health-related social needs, and then taking advantage of those. So using the anchor institution of a hospital or a health system to now bolster the opportunities to invest in communities is a real boon, I think, for the SDOH world, because it's going to allow us to continue to expand the imprint of health systems and to broaden what it means to be an anchor institution. And then the New Jersey Hospital Partnership Subsidy Program is another example of a partnership between anchor health institutions and finance. So health systems largely need to know, well, what would it look like for me to partner with a local bank? What would it look like for me to partner with a large financial investment institution to improve outcomes for vulnerable populations? And so these studies are going to continue to come out that not only define or characterize the investment, but then examine it over the long term to see what's the impact of that work and how it's traced to health outcomes. So forgive me because my talk ended up being shorter than I anticipated. And I think maybe it's because I'm excited about the topic and ended up talking a lot faster than I meant to. But when we really think about health-related social needs, we need to understand that everyone is impacted by social determinants of health, but only a small subset of people have unmet health-related social needs. And as we're screening for social determinants of health and identifying those at risk of unmet social needs, we're going to have to be really to maintain a high level of responsibility for that work and not put an undue burden on already vulnerable people when it comes to screening process. Secondly, place matters. So where you live, work, learn, and play impacts your health outcomes. And you're going to see this over and over and over again, regardless of where your patients live. And being able to not only just understand it, but then to articulate it when we're sitting in the clinic is valuable, because it can validate what are some of the challenges when we're talking about physical activity and not living in a safe environment. How are you talking to your patients about that? How are you engaging them in ways to improve their own health outcomes without having an undue sort of focus on things that are out of their control. Health systems have a role to play, and that role is going to continue to change and evolve, not only as we think about um, where we're investing, but also as we're thinking about population health and value-based care. So, that's the world in which I am most passionate about. So when we talk about working with insurance companies to improve our value-based care contracts or working with populations of patients to improve outcomes, we have to be cognizant of the various things that affect those outcomes and then investing appropriately to try to really move the needle. And this is where public health, population health, health equity, hospital systems all converge in a meaningful Venn diagram, because we're going to have to figure out not just how to uh, identify and understand the things that impact health outcomes, but then we're going to have to actually work to improve them, because it will mean that we're incentivized to do it in a more meaningful way. And health systems are going to have more, I think, flexibility from a financial perspective to invest in these other health-related social needs to improve outcomes and improve our performance and health in our value-based care contracts. And then lastly, the thing to really think about from a physician perspective is, we have a role to play in advocacy for public policies that affect patient outcomes. So this Medicaid disenrollment is a perfect example of how a public policy for our Medicaid wind down is absolutely going to adversely affect already vulnerable patient populations. Or when we think about various policies around food access, around SNAP benefits, around early childhood education, going back to the very beginning about what does it really mean to affect a health outcome, the medical part is 10%. If the medical part is 10% and everything else is 90%, then as a well-meaning physician, I feel like it's incumbent on us to try to work in some of those policies and procedures that are absolutely going to help impact our patients. And that's kind of a plug, I think, for everyone to say, how can you get more involved in an advocacy way that's meaningful and impactful for our patient populations? And then, when it comes to data, I really encourage everybody to try to get more information, understand what data is available for you and for your patients. So the CDC has social determinants of health data that's looking at huge populations. We can talk about census level data. You can talk about individual community data, neighborhood data, state data. But realistically, as a physician, we need to understand the larger population in which we care for. And what does that look like? What are the health outcomes? That starts to put a finer point on what are those health-related social needs that someone might have in the communities in which we serve. The other part is this countyhealthrankings.org. And I will say every single one of us who engages in teaching medical students should get used to this particular website. So with countyhealthrankings.org, you can go tell them, hey, I want you to better understand the disparities between two counties in Arkansas. Dig down deeper into, what are some of the unhealthy behaviors that are driving outcomes in two disparate counties. The other interesting part, or the cool part about countyhealthrankings.org, is that they will match not only the data with it, but they also will talk about interventions, not only interventions from an individual community level, but policies. So like the Safe Bicycles to Work project, what were the outcomes for that? Or investing in community gardens, what have been the outcomes for that? So on countyhealthrankings.org, you can not only look up data for your county or neighboring counties, but there's plenty of information on interventions and what's the outcomes for very specified interventions that you might then want to try to improve your own neighborhoods. A project that I did with our med students is I asked them to get on countyhealthrankings.org, identify a social need that they felt like was particularly meaningful, then go research what were the opportunities for improvement and present it back to us in terms of what might be a meaningful way that a health system could navigate these complex social problems. And then lastly, this neighborhood atlas, that's what the social vulnerability index. And within the social vulnerability index, it's a multifactorial way of looking at places and where there's increased social vulnerability. It hinges on transportation, neighborhood, like the built environment, walkability, schools and education, probably medically underserved neighborhoods. And it's in that constellation of risk starts to put an actual number on where are vulnerable patients in our neighborhoods, and then what could we do about them. So the more you know, the better you can be. And truly, from a data perspective, I would encourage everyone to take a little bit of time to play with some of this information so you can get a better picture, not just of what we kind of already know anecdotally, but to put a finer point and a percentage around some of the work, so that in turn you could pick something that you wanted to go invest in, or you wanted to encourage your clinic, your community, your neighborhood group to try to improve, because it's going to have a direct effect on our patient populations. And with that, I'm done early, so I'm going to go to some questions. Elisa says, how can I give an example of how you can advocate for improving patient outcomes? Oh, me personally. So when I think about, one, I'm on the board of the Arkansas Medical Society, and we're talking about how we are going to work as physicians and advocating for physicians, but also what's our role as physicians in advocating for patients. So going and talking to your local congressperson, getting a better sense as to what they're doing from a public policy and governmental policy perspective is really valuable. And they often have no concept of what it means to practice primary care in the state. So if you're interested in advocacy, I would have in the context of all of the myriad of things that contribute to poor health outcomes for your patients. And then you go to them, you go to your congressman, congresswoman, and you tell stories. My patient experienced this. This is what I saw. This is what happened. This is how changing this policy would improve their outcome. Specifically around Medicaid disenrollment, I talked to some congressmen about my patient who was Spanish speaking only, who was getting letters in English that he didn't understand, clearly needed Medicaid, and was kicked off and then wasn't able to get evaluated for a kidney transplant. So little things from a policy perspective where a vulnerable person is much more apt to fall through the cracks. There's impact to be made. And remember, physicians have weight. So people listen to doctors in many ways. If you're going to go and talk to people in your community who have some authority, I think generally they listen to us, which is a gift and a privilege. Another question. Okay, the state health department has government programs to address some of this. In your opinion, where are they going wrong given the state isn't improving? Anybody who's worked with the state health department knows that it's a very difficult bureaucracy to navigate. So I think that realistically, we struggle with state government led. Something that's only state government led is going to be less effective than a true collaboration between an anchor health institution, a nonprofit organization, and the government. So I think that's where we have sort of gone wrong in our state in some ways, is that we haven't truly bridged the divide in those collaborations in a systemic way. Certainly there have been wonderful pockets of improvement, but the question around bigger systemic interventions, I think, is an important one. Next question, how can we engage with legislative and other groups to tap into advocacy work and utilize available resources? There are a variety of legislative and advocacy groups you can engage in. You can start with the American Medical Society. You could start with, under family medicine groups, your local advocacy groups. If there's a specific area in which you're interested in, talking to your local representatives who are, we employ them. really thinking about how to do that work. Also, UAMS has resources around legislative advocacy if you're interested, and you can go speak to our legislative advocacy groups to get a sense of, what is UAMS doing from an advocacy perspective. They're often looking for physicians who will go speak to legislators. So thinking about that. But what I would say is that the bar is pretty low. If you have a little bit of interest and a little bit of enthusiasm for it, there's so many opportunities to get involved. Next question, is there any collaboration that coordinates physician efforts to make a difference in their communities at this level? I don't know that in terms of something specific. It's really that's gonna harness the physician level work. I'm not sure. I think we'd probably have to think more on a systems level, and meaning the UAMS system. What are we doing to harness physicians? What partnerships do we have? You see this in our Office of Community Research, which is incredible, right? Like the work that we're doing around community research is amazing. As a practicing physician, I find that it's, for me personally, because one, I'm in a hospital-based clinic, I don't see the fruits of that labor. And I think continuing to expand those partnerships for individual physicians with the research that we're doing around community work, and then taking the information that they're provided through research and having sustainable interventions that go well beyond whatever that funded grant is, there's a real opportunity there. And I know that they're plenty motivated to do that and very interested in doing that. But often it's a tension between the provision of care, which we see in the clinics, the research, the community engagement. There's so many silos at play that make it difficult. Okay, next question. How can we help our residents and students account for the impact of social problems and vulnerability on health-related behaviors? So not judging people too soon. This is a really good question because I often worry that in framing the discussion around social determinants of health or adverse childhood experiences, we end up pointing a finger at vulnerable people. So I gave a whole talk on shifting the conversation away from what's wrong with you? Why are you acting this way? Why do you keep, having these terrible behaviors? A good example is my sickle cell patient who's constantly in the hospital, but never follows up with her hematologist, isn't consistent with taking her meds, knows that she needs to be in therapy, but doesn't. It's frustrating at the provider level because we think, why aren't you doing this thing that would make it better? But realistically, she's had a whole host of adverse childhood experiences, one among them just having the diagnosis of sickle cell disease at an early age counts. But in turn, shifting that conversation from what's wrong with you to what happened to you is an important shift. From a medical and student and resident perspective, it's trying to help them find the language to unearth some of the contextual things that impact someone's health behaviors, validate that it's challenging from a patient perspective to get something done, for instance, and then collaborate with the patient to do more patient-led decision-making can be important. That was a complex way of answering that question, but I think realistically it's language. The best way to talk to medical students and residents about the impact of social problems is empowering them with the right language to talk to patients, to hear their stories, to not be judgmental, but also to validate some of the challenges that someone might have for controlling chronic illness in the face of serious social, emotional, financial problems. But with that, I'm sorry that my talk was quite short. It was not my intention. I hope it sparks some interest with you and with your patients to think about the impact of place and community, and then also what you can do in your own community to improve outcomes for your patients.